सुरासुरवन्दितपादपद्मम् लोकेर्जरारुक्भयमृत्युनाशम् दातारमीशं विविधौषधीनां संयोमवातावनिवारिवहनिं पंच प्रपञ्चात्मकदेहभाजम् सन्तापसम्पातजराजरान्तं नमामि धन्वन्तरिमादिदेवम् नवीननीलमुदकान्तिकान्तं शान्तं हरैर्द्वादशमाख्यमूर्तिम् मूर्तिं शतानां सुमनोरथानां नमामि धन्वन्तरिमादिदेवम्.
Please be seated. Moving ahead, it's our honor to welcome our chairperson, Dr. Reshmi Pushpam Ma'am, Professor, Department of Agat Tantra. We are truly privileged to have you as a chairperson for today's session. Next, we take immense pleasure in introducing our co-chairperson, Dr. Deepu Manohar Sir, Assistant Professor, Department of Rachna Sharira. Before we move ahead, let us acknowledge the guiding force behind the smooth conduct of today's proceedings. We are delighted to introduce Dr. Dhanya V. Nair Ma'am, Assistant Professor, Department of Panchakarma, Guru Gorakhnath Institute of Medical Sciences. Now it's time to welcome and introduce the distinguished resource person who will enlighten us with their profound knowledge and experience in today's session. It's our honor to introduce Dr. Vittal K Huddar Sir, Additional Professor, Department of Kayachikitsa at the All India Institute of Medical Sciences, New Delhi. Dr. Vittal Sir is a renowned clinician researcher with exceptional expertise in Ayurvedic medicine and integrative clinical practice. It gives us immense pleasure to welcome Dr. Alex Hankey. Alex Hankey, Sir, Professor Emeritus of Yoga, MIT, World Peace University, Department of Biosciences and Technology. With his vast international experience, he beautifully bridges the gap between traditional wisdom and modern science. Now, I would like to invite Dr. Deepu Manohar Sir to kindly give a brief introduction and extend a warm welcome to Dr. Vittal K Huddar Sir.
Good morning, everyone. It's my pleasure to introduce Dr. Vittal Huddar Sir, an accomplished scholar and a clinician in the field of Kayachikitsa. Currently, he is serving as an additional professor in the Department of Kayachikitsa and holds his degree of BMS from KLE Belgavi and MD from the SDM College of Ayurveda, Udupi, and PhD from the KLE University. Over the past 17 years, Huddar Sir had made remarkable contributions in both academics as well as research, having served as the head of Roganidana Department, coordinator for the Center of Oncology, Integrative Oncology, a joint initiative by All India Ayurveda, AIMS, ICMR, and NICPR, and as a member secretary of the Institutional Ethical Committee of All India Institute of Ayurveda, New Delhi. He has guided several research projects in collaboration with the premier institute like CCRAS, ICMR, AIMS, and ILBS, and has numerous publications in his credit. His dedication and leadership has earned several honors, including Goa National Award for Excellence in Clinical Services and the prestigious Ayurveda Marthanda Award. So please join me in welcoming Dr. Vittal Huddar Sir on his topic, Integrative Medical Oncology and Ayurveda Perspective. Please.
Good morning to all. respected dignitaries present over here, and all the delegates from different parts of country and other countries. Uh, so first of all, I would like to thank the organizers, particularly Dr. Vedantam Giridhar sir, and for giving me the opportunity to share my few views regarding integrative oncology. So all of last 2 days, all of them are talking about the integrative medicine, and all of you now came to know, or maybe knowing, that the integrative medicine is the future medicine. It is said as the future medicine because of the benefits, limitations, strengths of different system coming together to make a best model of successful practice. So in this regard, it is true for all the most of the chronic conditions which we come across in our clinical practice. The integrative medicine plays an important role. So it is very true for oncology particularly, where the limitations of a conventional medical system is encouraging, and they are looking towards us for integration for a better management of such a dreadful and unsolved condition till now. So as all of we know, it is the burden of this cancer, then the number of patients is go on increasing, and the burden, economic burden to the countries is increasing worldwide. And India is third place in that after China and US. So this is the trend, how it is going on. And we also notice that one of the other, even our surrounding, not only in our surrounding, in our relatives, one or the other person may be affected with the cancer. And most of the times, it happens to ourselves also, that sometimes it's not it's very uncertain that anybody can get in such a situation has been created because of our lifestyle, maybe environment, many things are there in that. So the leading cancers presently in males are lung cancer, followed by the oral cancer, and in females, breast cancer, followed by cervical cancer. So this is the statistics which has been taken in children also 0 to 14 years. They are very unlikely to get a cancer, but the lymphoid leukemia is the one leading cancer in those children. Even we get a patients of 2 years, 8 months, 1 year child in clinic type of problems. This is the data from ICMR, NCRP data. So increase by 2040 is almost 57% has been predicted. You just think 57% increase in cancer cases. We need to work on that, and integration and the strength of Ayurveda in prevention or improvement in the lifestyle. What we say a lot of time, but we need to make it practical, reach it to the people. From the primary health level, we can do that. So that is different things we are going to discuss. What exactly the model of integrative oncology, what we are doing right now, and what are the projects, and what are the work we are doing now in the clinics, and what is the expected future. So just in last 3 days, I will not be going in detail with these slides as a general integrative medicine. As the WHO says, the traditional, complementary and integrative, traditional, complementary and integrative medicine. These are the 3 words. So many times, even our PhD scholars and even faculty also, and even from the government ministry also, we get some document using the word alternative medicine and complementary medicine for Indian medicine. So these are some of the terms just I have highlighted here, that the traditional system of medicine is own of its country, whatever it may be. Either it may be complementing or it may be alternative, whatever it decides by the time and the situation in the individual country. So better we use a traditional medicine word rather than using ourselves directly as alternative medicine or a complementary medicine. So the meaning, very clearly the WHO has given the guidelines for traditional medicine. What is complementary? Complementary is what is conventionally maximum practice is going on, to that complementing. It may be either a traditional or whatever it is. nothing to do that. So integrative medicine is the combining of all these, either traditional of that own country as well as any system of medicines which you can do better and integrate them in your practice and make a best model of creating the practice model. Okay. So this is the integrative medicine which mainly focuses on health, healing, and then the disease and the treatments. The health and healing, disease and treatment. The integrative medicine includes many things, many other aspects we call as the the lifestyles, what we say, achara rasayanas and everything. It completes holistic approach, what we call. So that makes these towards health and healing rather than the disease and the treatment, which the conventional medicine is going on, is concentrated on. So why integration is needed? It is true for all other conditions, chronic conditions, and it is more true in such a condition where I have highlighted for the cancer. This integration is because of limitations in the standalone treatment of any system of medicine in cancer management. That is because of the adverse event, either it may be adverse event by the conventional medicine or a lack of curative treatment in particularly in any type of cancers. So that makes us for integration, opens for integration. And patient demand for holistic individualized care. Because of that, the patients are looking towards the alternative things where I can get a benefit. So a lot of patients now for cancer, even for other diseases also, but now for the cancer, they are looking for the alternative solutions. And based on the data, it has been said that 70 to 80% of people in any countries, in many countries, they are using traditional medicine. So this is the truth that is going on, but we are not making that as a conventional system. So this is because of some, all of you know that the evidences and the process of validating and coming to the convention, how the allopathic system of medicine has came till now. So in the pathways of bridging of these things and one or the other day in long way, in a particular key areas where Ayurveda makes strength, it may become a conventional medicine. And in some conditions, allopathy system become a conventional medicine. It goes on. So scope for combining strength of both system is for improving the quality of life and reducing the symptom burden and prevention of recurrence and such things, particularly in cancer. In terms of cancer, I am telling many other such conditions we see in OPDs, chronic illnesses, which has not been in hepatobiliary conditions and many other conditions, we see that we alone better cure than that of the allopathic system also in practice. But in cancer, particularly, rather than saying cure for any patients, misleading such a patients, we are telling the truth to the patients that what we are exactly doing with you, that to make them a symptom burden less and quality of life is going to be improved. And certain areas, different areas are there, how we can go for the models which we see in the next few slides. So integration is possible in 3 areas, all of you know, academic, research, as well as in practice. So in academics, so many things in the NCSM revised syllabus also, there are some electives are given, many things are there that we should know about the other system of medicines, basic sciences, basic medical sciences, knowledge, everything, because sometimes we feel that at certain level we go, as a clinicians, we lack in some of the basic related sciences where we cannot understand the language of that research, what they exactly want. They talk about the pathways, genetic, all the mutations, all these things we should know. As the electives, the syllabus, academic integration can be done in different areas. Curriculum development, interdisciplinary teaching modules, PG and PhD electives, and guest lectures and workshops by the faculty of both the system that is going on. Faculty exchange programs, joint CME programs. So CME training, workshops, online and offline courses can also be offered to sensitize, because all of this is because without the academic integration, without the understanding of two people with the academic angle, it is not at all possible, because if they understand our basics, not exactly the whole system, but what the strength of other systems are there and what we are weakening and vice versa with the other system, and integration of the two physicians, if it happens with the help of this academics, so then only it is possible further researches, practice, everything go in line. This is the basic thing. And in research integration, again, the integrative protocols, particularly in cancer, where exactly how we are going to understand how the patient comes to us and how we are categorizing them, condition they come, what we understand it by Ayurveda, what allopathic system is having a strength, if it is not, where to patient go. So all these charts of integrative protocols are to be developed based on evidences. Rather, we can make a hypothesis initially. We are making some protocols where hypothetically based on the consent of the practitioners of both allopathic system and Ayurvedic system, we have developed few integrative protocols also, which can be validated later in our clinics also. We are behind that, and EMR and IMR projects definitely now it's an open area and very in any funding agencies, if you see, the cancer is and the non-communicable disease is a priority in any such type of researches. So that is the research integration and publications. No doubt you all of we know we should be behind these quality publications, that this is only the one area where I think in for research also, if you are going to do any some projects, you propose some project, definitely there should be some publications to the convince the safety and the efficacy of our drugs or the formulations. So that is a very big task and the challenge. So for that we should have a proper publication so that the research becomes easier. So presently many funding agencies are there where we get a fund, lot of things are there to explore in research areas. Just few things what we approached I have put, otherwise there are a lot of funding agencies are there we can approach for that. So we are now with the Ministry of Ayush, CCRS and ICMR is also very positively coming for the integrative project, especially for cancers. And also they are a little bit in IC, they are not so stringent nowadays and they understand the things, what exactly the traditional medicine is, how it is well established, it is well proven. That's why there is amendment has also been done in ethical guidelines also. If it is traditionally mentioned, classical mentioned, doesn't require any preclinical or animal experimentation. Such modifications are going on. So we are getting a pro thing from the policymakers also. We can make use of this for the integration purpose. So implementation plan we have started in our unit, started with the OPDs. That is the first step. Later, once the interest in the number of patients are going to increase, we are thinking of making it different satellite centers. Later on, we are doing some satellite centers in different allopathic hospitals and in government hospitals like AIMS also in Delhi. And then later, we can develop our own areas where all the system of medicines, for example, chemotherapies, radiotherapies, the allopathic physician will be there and we are sitting together. Either we go there or we can set up our own, it depends, whatever it is. But once the patient comes there, positively the patient should get a proper information where exactly the patient has to go. There is a lot of gap between still now in practitioners. They will not accept our system of medicine. Once the patient goes, a lot of people are there who are very pro and they understand the things. That's why I told the physicians integration. They come to us. Whatever the projects we are still doing, they all are invited by them only. Not we have not initiated much. So that much of interest is also going on in the integrative research projects. But practitioners who are not into research, they are only on practice, they will definitely deny the treatment taken by the patients from the alternative system of medicines, and very rudely they sometimes talk to the patient. That is very pathetic condition. Lot of need things to be done in integration to reach out to that position. So here we have different branches, and now earlier one person used to start from one department and we are developing, and then he is looking after all the areas of research. But now we have opened it after 7-8 years. We have opened it for all the departments, and each department is sitting into the OPD and they are doing their best in the clinics and in their areas, as I have mentioned here. So they are going to work in this area. So this also refers to cancer where each department can contribute very well, because only one person cannot do in all the areas. It is best we can see all these areas. Pediatric oncology, we have pediatric patients. Now we have segregated them to the pediatric. They are best in that. I am best in some other conditions, hepatobiliary, lung cancers, leukemias. We are looking after as a medical oncology. Other persons breast cancer, cervical cancers, wound care, surgeries. So all they are having a strength that needs to be explored. Not a one person is doing for cancer. It is not like that. So these are the areas where one can develop their own branches as particularly related to the cancer. So in the services, definitely, as I have told, need to start. Either anyone has to start with the OPDs, then satellite clinics. Referral system need to be developed because we should have some SOPs for the referral. If you are working in a satellite units, we are making that SOPs when they are going to. It's again a challenge when they are going to refer to us. So all these are the SOPs, and we need to convince them that they will ask question. Which patient I have to refer to you, tell me. So I don't know anything about that. So how I can refer that patient to you that you have a strength in that. So what, after long discussions and all, we requested them, we will show and weaknesses, whatever it is there. Let us interact us with all the physicians, every or in the tumor boards or wherever possible. They are going to sit weekly in NCA. I am talking about. So there they will sit weekly once for their discussion about the patients, no OPDs. Weekly once they will sit together and they discuss among themselves. So if they get a place in there, we can tell our strengths and weaknesses in that with evidences definitely. Without that, nobody is going to listen to us. So that what we have made now is a one small book of published, at least published areas where the clinical studies have been done. At least these patients you can refer to us. So in that way, we have started with the referral system. So such SOPs and other things are there. Definitely evidence-based practice. Generally practicing is different. Patient knows, I know, patient is very happy. I am giving the result to the patient. They are also very happy. But the evidences sometimes we don't generate because of the situation. So that is very needed in case of cancer practice. Also proper proformas, we should have proper assessment methods. We have each and every patient. Now we have started with all the things by making a team. It's not possible only the physician can do all the things. So all the internees or the PG students, PhD scholars, all are involved in that, gathering the documentation, and the physician will lastly analyze all the thing and prescribe. So documentation automatically it's going on now. So that needs to be done on the day one actually. So patient education is also very important because lot of patients are going wandering here and there. Still now, the patients are not aware about where to go, when to go. In particular, they are going to some unauthorized practitioners also in the time, and directly they will send them to the tertiary care allopathic hospitals, and they say that this is the happening with the traditional medicines. They will brand that, you will waste the time and you will worsen the patients, and then you send it to us. That is the image. That's why they deny. There is nothing wrong. They are denying because of this reason. So that we should take care and we should educate the patient properly. At this, you should go to the conventional. What is the protocol? So in this condition, you should come to Ayurveda. That knowledge has to be go to the all the patients. So that patient education is also very important because many reputed such institutes, I have seen the patients coming to our practice. They are all their branches are established all over India and even in abroad also. But what they are exactly doing inside, once the patient comes to us and what they have went through and how, then we will come to know how they have guided. So misleading should not be there. So that we should take care. That is only the negative point from our side. The allopathic people are against us. So that is to be taken care in the services. So in AIA, we have a MOUs with all these partners. So National Cancer Institute, All India Institute of Medical Sciences, Delhi. Actually, it is situated in Jajjar. It is a part of the AIMS Delhi only, dedicatedly set up for cancer practice there. And we have a satellite center and AIMS New Delhi, of course. And National the Institute for Cancer Prevention and Research. It is the ICMR branch which works exclusively on preventive oncology, where we are also collaborated with that, and Center for Integrative Oncology, which we have established 7 years, 8 years before, is the joint venture of these. And the ICMR also we have, and then EIS Japan also we are taking up some projects with the AIST Japan and CCRS and IIT Delhi. So now we are working. Actually, these are all working MOUs, not on paper. Actually, we are each of them are having some projects in this we are doing. So this is a Center for Integrative Oncology 2017, inaugurated by our previous director, former director Abhimanyu Kumar sir, 2017. And Integrated Cancer Care Unit OPD has been inaugurated by sir, Ministry of Ayush, 2018. Till then we are started our journey. We have 71 patients at that time. Now it is almost 2,000 patients in a is going on. Totally now we have more than 9,000 patients who are approaching to our institute. That's only weekly once we run a OPD actually. Otherwise, it is burdened with all other conditions, different conditions. Daily OPDs are going, but we have started one OPD exclusively for that. Now it is running 7 days a week. So these are the leading cancers which we are getting in our OPDs. Again, highlighted one: breast cancers, oral cavity, tongue, lung cancers. Lung cancers are also more, and hepatocellular cancers are also more in our OPDs. So this is the one workshop, GGIMS, which we have conducted in 2020, and again later also we have done that, a continuation of that. That is the seminar and workshop. It was a national level workshop. And we have taken in the workshop, we have taken a project on developing integrative protocols on pancreatic cancer, hepatocellular carcinoma, leukemia, lung cancer, and breast cancer. Now, two we have released. One is breast cancer, and another is leukemia. Other three are yet to release. So again, 2023, we have called almost all the leading practitioners from all over India in Ayurveda, also from AIMS and Tata Medical Center. So there we have called the experts and we have taken their opinion. This is the understanding what we have made the base draft, and they have given their inputs. This is the area where we require the interventions, where the patient comes like this. So what we have to understand, the diagnosis of that, accordingly the plan of that. So in that way, we have developed the integrative protocols. So capacity building program, CME conducted separately for oncology, not for the any department. For oncology separately we have conducted. Annual observances we do regularly, awareness days and other things. This is the satellite center of NCI. 2000 it has started. Now patients are coming without, they are referring few patients, but patients are by themselves they are coming. But that is not our intention. Our intention is to get the referral from the physician. That is the intention. Otherwise, the patients are coming to our center also. That is nothing more in that. That doesn't mean an integration. Integration is once we understand they refer, I refer to them. So that is required. We are working on that. So these are few of the publications, as I have told, on the algorithm on integrative management of breast cancer, released by the Honorable Justice of India, D.Y. Chandrachud sir. And this is our new journal. Now the 4th issue is coming. Ayush Journal of Integrative Oncology, where exclusively we are inviting the single case reports, original articles, review articles and all. So exclusively for cancer, this is the first of its kind in Ayurveda, particularly Ayush Journal of Integrative Oncology. So who are interested in that, have worked on that, we can take that into a different platform separately, and we can take that, the impact of that journal to such a level that they can understand once it is published in that. Okay, this is the right thing. The conventional people should get it. That is the intention. With that, we have started this journal. So few of the publications we have done, that is on CLL case reports and exploring the properties of medicinal plants against breast cancer by down-regulating human epidermal growth factor receptor 2 in good publications. Just few of them I am mentioning. Cancer Research, Vardhamana Pipali Rasayan and its effects in the preclinical studies. And the integration of Ayurveda in the management of multiple myeloma, also we got very good results. We have published that. So these are few of the, again, frontiers. It has been published, chemoresistance and systemic therapy. Review on integrative approach in oncology, bridging Ayurvedic medicines and modern cancer therapeutic, again, frontiers, review articles. So few of the ongoing projects. The breast cancer AIMS ICMR, we are started with breast cancer and Vardhamana Pipali Rasayana, it's going on, ICMR funded. So, and then with the CCRS funded, Nandi Medugu stage 1 and 2 breast cancer conditions. We are getting very good results with that medicine, so we have taken the project of that. And few of the completed projects, the with AIMS again, the lung cancer, non-small cell lung cancer, Vardhamana Pipali Rasayana, because very few single drugs we are taking in high dose. That's we thought, because otherwise taking a formulation, justifying each and every drug, herbo-mineral preparations, lot of resistance is there. They are not going to believe. So that is the problem with the research. But we have taken single drugs, not only a single drugs, because it's very tough to manage with the single drugs. You know, in all the chronic conditions, either if you take also will not get the results. So that will be the situation. So as far as possible, we want to make as a protocol with Panchakarma and other things. If we do it in our center, definitely we do different things there. But this is with the AIMS. That's why we have taken a single drug or the Manapipali Rasayana. In the IIT Delhi also we have done one IMR project where the saliva is having some early detection markers. So for identifying the breast cancer, that study has also been done and it is published also. There are few of them upcoming projects are esophageal cancer along with the NCI AIMS Jajjar and oral squamous cell carcinoma and ST Madhu with ST Madhu Grita and Kashaya and Taila application AIST Japan. Chemotherapy induced myelosuppression, we are working with NCI Jajjar again. And KAP studies are also required, as I have told, the knowledge of the patients, what exactly they understand when they come to us, what is wrong in that, what is right in that, we want to know that. That's why we've taken a few projects like that also. So just in brief, I will not go in detail as the time is already running late. So just few of the glimpses we need to understand. So exactly one condition we cannot mention for the cancer once the patient comes to a different type of cancer patients, because they will come. So the Gulma and such concepts are there, which has been isolatedly explained in the classics, where there are separate entity where Mamsa Meda Bahulyata is there and Kapha Bahulyata is there. For that, the line of treatment is mentioned as Karshan. Big Tikshna drugs have been mentioned, external applications, many things, Shodhana, everything has been mentioned. For that is not true for all the patients who are coming having Arbuda in different systems. It is not possible. If that Arbuda, if it is present in a brain, if it is present in a lungs, if it is present in a renal, if it is present in a liver, so the patient comes to us with a different classical entities and the diagnosis will be accordingly. We need to manage. Either first we have to manage the symptoms, either we need to manage the complications first, and then once the patient is little bit controlled, then we think of the line of treatment which has been told for Arbuda particularly. The such drugs can also be included, and Agadasam preparations also we include in our practice considering the cause for that particular cancer, suspected causes for the cancer. Likewise, we consider these Visarpa, Dhatugata Jwara, Pandu, Kamala, Rajakshma. As I have told, if the respiratory related lung cancer patient comes starting from simple cough, unidentified, symptomatic, started with a cough, dry cough, productive cough, hemoptysis, weight reduction, Rajakshma line of features, Ojakshaya, all the dhatus. So all the lines we need to think of the disease, dosha, doshas, which are involved in that, and accordingly we are going to take the different Chikitsa sutras either from the dhatu, the Dushti Chikitsa, either from the Doshopakrama, either from the disease Chikitsa sutras. Likewise, we take and plan the treatment. So that will be different for different patients. And so doshas and dushas, if we see, as I have told, for the Arbuda, if you consider, that's only Mamsa, Meda and Kapha. Otherwise, so otherwise in different conditions, the patient will come to us. Usually they will be presented with the predominance of these dosha. It's not absolute. It varies from patient to patient, just for giving an idea. So in this condition, if the during chemotherapy, usually we see the predominance of Vata and Pitta. So accordingly, different either there will be Agnimandya, Ajirna, Tisara, many situations will come to in front of us. We cannot say some kapha will not come there, but it comes. But we need to say most of them will come with a Vata Pitta predominancy. Likewise, post-radiotherapy, after surgical removal and debulking surgeries in glioblastomas, brain surgeries, on relapse, palliative care, and some of the other conditions where Agnimandya, Ajirna, Dhatukshay, all those things are there. I will not be going in detail with that. So just in a Samprapti, how it may be going on in the the condition, the patient of cancer, Some patients will come to us, they have not indulged in any risk factor like smoking, alcohol, nothing hereditary, no, nothing is there. Some patients directly they will get, oh, why these things may be happening. It starts with these, I think, Mityahara and Vihara, Achara, lifestyle disorders, non-communicable disorders. So I try to make out some of the indigestion, flatulence, constipation, fatigue, excessive salivation, heartburn, such things continuously going on, treated properly, goes for a longer time. Then in allopathic conditions, we think that the free radicals, oxidative stress, such things are going on. From Ayurveda perspective, we see Agnimanda, Ajirna, Ama, Srotoroda, then the deeper dhatus are involved, then impaired metabolism starts, and then they lead into some of the conditions, lifestyle disorders, what we say, all of these are having these type of nidanas basically. So amongst them. So basic thing what we have to concentrate for the prevention aspect is again all these things, whatever the causes we suspect till now. So genetic factor is there definitely, bija dosha and dushti prognosis, that is a different aspect. So once they start the treatment again vata pittahara, and once they are having in lifestyle disorder NCDs, cancer, kaphamedohara drugs, arbuda, gulma, granthi, chikitsa, once they will land into treatment and the further course of the cancerous condition, they land into Vata Pitta Chikitsa, and later Vata Hara Brahmana Chikitsa is needed at the last. Other Rasayana therapy also comes into picture. So the Rasayana is also a Rasayana, concept of Rasayana. Many practitioners are using this because we have only tool that Rasayanas for the preventive aspect, for the treatment aspect, and to correct the tissue metabolism. Dhatu portion is very important because we know that there is no infection, no nothing, inflammation, nothing. It initially starts with the tissue, the improper metabolism of the tissues leading to the excessive growth of the cells. So there is no cause. So to make that, what we have to make is we need to keep all the dhatus at the prashasta level. So the rasayan is the best concept for that. So that is the use of the rasayanas in general. If we see all the falashruti of the rasayanas, what we see, almost all these are useful in one or the other conditions of the cancer patients suffering with the different system disorders, different srotas related. So you can see here all these falasrutis. Rogapara, Chintyadbhuta Prabhava also, we work on that also, isn't it? Prabhava, Nidra, Tandra, Shrama, Klama, Alasyahara, Daurbalyahara, Anila Kapha, Pitta Samyakara, Stairyakara, Vaddha Mamsahara. So particular stage where the chronic patient comes to us at the end, all these Rasayana Falashrutis, we need to keep it in mind accordingly. We need to plan. So this is one concept particularly proposed by Professor B.S. Prasad sir. That is the tissue metabolism, dhatu poshana, and advanced cell theories. So that may be true, the hypothetical. We need to go for a research in that. Means this one cell dividing into different cells and making a finally a end product of that. It starts the stem cell division and all the same rasa, rakta, mamsa, meda. So if you correct the basic level, all these things will be stem cell therapies and other things are related to the dhatu poshana somewhat. I'm not going in detail. It's a big topic again. Just a so you can see here in this level. So here just I think it jumped from once. Where it has jumped, I don't know. End of the slide, it has went now. It is, I think, yeah, it's here. Yes, it was here. Yeah, this one, as the stem cell give rise to functional tissues, Rasayana drugs are supposed to act on stem cells. Tissue system specific rasayanas are likely to act on that particular stem cells. So we have a particular srotas and particular rasayanas. So particular stem cells, it is going to work in that way, it is postulated. Rasayana drugs for vayasthapana enhance the cell proliferation capacity of the stem cells. So that is dhatu poshana and the rasayana. So these are few of the rasayanas which we are practicing. Vardhamana Pipali Rasayana, St. Madhu Rasayana, Bhallataka Rasayana, Guduchi Rasayana, Lashuna Rasayana, Navajivana Rasayana, Amalaka Rasayana, Shilajatu Rasayana, Bala Rasayana. So many drugs are there which will be given in a single drug and also in a increasing decreasing order or in a maximum dose given for a month. So different practices are there to practice the particularly for rasayanas. After Shodhana, we usually plan most of the times Pippali Rasayana, ST Madhu and Guduchi Rasayanas we practice. So that was that Rasayana type of practice was initially started with late respected GS Acharya sir. That was even that we are also adopting in case of cancer's conditions also, and it is certainly good. And we have done that research before. Also, I have told the lung cancer it has given very good results also in that. Not exactly in the curative aspects within 2-3 months, but at least reducing the toxicities and the symptom burden. Definitely, it was work there, and we are going to publish with the aims only because the principal investigators are also from both the sides. So they also very keenly seen that and they have appreciated that also that we are going to publish. So these are the rasayanas, we can divide them in the practice like preventive and once it is manifested. In the preventive, 3 group of people we get. If we want to implement that preventive model into the healthcare, so these 3 type of people we will get. One is positive family history patients, another is exposed to risk factors, no family history, and no history of cancer and not at all exposed. These 3 category of people are there. All of them we need to concentrate, and if positive family history is there, particular cancer, particular srotas and particular rasayanas we can plan them, Shodhana and rasayanas. And exposed to risk factors, regular Shodhanas are indicated particularly for them. Even previous conditions, if not Shodhana will work, but here for the who are involved with the risk factors like smoking, alcohol, such patients needs to be undergo Shodhana properly at least twice in a year, take 2-3 months rasayanas in a year. That is possible to explain them and it can be made. And no history of cancer and not exposed. Such people are also there who they want to live healthy. Such a group of people are there. So we can ask them once in a year, we can take Shodhanas, particularly Rutu Shodhanas, and lifestyle modifications we can advise, lot of things. So that has to become like a tradition. Now the taking these junk foods has become a tradition. So likewise, why not the lifestyle of the earlier style can become a tradition? So if we go in certain areas, like if you go Kerala, if after some functions they will give some Ushira or Khadira, something to drink. That is a tradition, isn't it? Why can't we follow traditions in that area at least, different areas? The local tradition, if at all also followed, we make them to follow that. Separate unit needs to work on that and primary health level. That is a bigger task actually, but government is also looking for that. Actually, they are making it to at a primary health level how to introduce this type. If it is there, then if we make at least a 1 or 2% change in prevention of many disorders, that's a great contribution from the system of medicine, what I feel. So these are a few of the, again, the rasayanas in Nitya rasayanas like Chavanprasha, Amalaka rasayana, Brahma rasayana, Haritaki yoga. These can be asked for the patient. There are certain category of patients, they will follow. Such patients at least we can concentrate. So once exposed to the factors, Naimitika rasayanas, for example, respiratory and GIT conditions, Vardhamana Pippali and Vallataka rasayana. GIT, lymphoma, blood cancer, liver disorders, pancreatic cancer, again Vardhamana Pippali rasayana and Guduchi rasayana we are practicing. Neurological, Lachuna rasayana and Bala rasayana. So with the side effects of the chemotherapy, anemia, bone marrow depressions are there, then Shilajatu rasayana. Hair loss and such complications, Shatavari, Narsimha rasayana. Renal impairment, if it is there, Ardharaka rasayana. So likewise, many things are there. Just few things which I have tried to mention here. This is a pattern. All of you know the classical thing. That is the Pravara, Madhyama, Avara, 10, 20, 30. Likewise, we do 10, 6, 3. So that is Pravara, Madhyama and Avara, Sahasra Pippali. That is same classical method we follow. Either the Pippalis we give, sometimes available capsules, extracted capsules of Pippali. That also we give in a 2, 5, 7, 10, 12, 15 and 17, 20 to 25 till 25 capsules in a day we administer, but most of them will tolerate 15 to 17 of capsule Pippali, and Sahasra Pippali 10 to 1000 they will take very easily. There is no much, very few patients, 10% of patients will feel some gastritis and all, until they follow some regimens like taking milk frequently, making buttermilk, or keeping them on a light diet, khichdi's, dal, something. Likewise, we advise them during this at least 19 to 20 days course, followed by one Kosta Shodhana. So that it can be practiced very well. So these are the probable mode of actions of Rasayana, which can be attributable, and their preclinical studies have been done, and all of you know, you'll get it through the internet. And these are the single drugs which are used in cancer, the preclinical studies. So clinical studies are very less, unfortunately, because almost all the preclinical studies have been done. They are not taken into clinical practice because sometimes they don't work in a practical model. Few of them we are using, but exactly taking that's why what we are doing now is the people who are coming from the laboratory, they will approaching the clinician, and we say them that we are using these formulations as a formulation, whole formulation extract they take, and they work on that, and then if results are there, then they try to identify which has worked on that. So likewise, reverse, if we go, then it's good. Otherwise, so many molecules going, each one of them, everyone is, all the molecules are having anti-cancerous properties, but once it comes to the practice, it fails again. So that is the problem in preclinical and clinical studies. So this is the integration may be possible from the ANC. We can think from that level also. We can study, we can take out the researches at ANC level also. Bija Dustis. So Matraja, Pitraja, all these Garbha bhavas are there, isn't it? Garbhini Paricharya and all, which will make the changes, genetic changes, and it may prevent from that level also. That studies can also be done who are having a history of family history of cancer, and longitudinal studies can be done by the institutes of national importance, or fundings are required for longitudinal studies. And here the therapeutic post-radiotherapy on relapse as a palliative care, primary prevention, chemoprophylaxis, chemoradioadjuvant as an add-on therapy, prevention of progression, and standalone. So these are the areas where we can work out. This is also in preventive aspects and in therapeutic aspects. We can make researches in these areas. For example, preventive aspect may help in optimizing the tissue metabolism, how the tissue metabolism, how it has corrected, that is another area of research, and may prevent abnormal cell division by checking the genes, that is oncogenes and the tumor suppressor genes that regulate cell growth and differentiation, further genetic mutations. So like that, the preparations we can take, whether it is working in this line or not. Therapeutic aspect, treatment supports without considerable complications. On the complications we can work out significant actions in reducing the side effects of chemotherapy and radiotherapy, quality of life, relieving the symptoms, increasing survival period, prevents the progression of the disease, reducing risk of relapse. All these are the words which you have used, are the outcomes which we can consider for our researches also. So these are our strengths, that is Shamana, Shodhana, Rasayana, Yoga, Pranayama, and counseling, particularly for the cancer patients. Each one of them are having its own importance. Yoga, lot of works are going on, Yoga, Pranayama, and this one also, and Prakriti and Actrek, the Tata, they are working on large studies that in their hospital, whatever the patients are coming, what is the response rate and what is the Prakriti of that patient. Likewise, they want to link. So likewise, many studies, observational studies, at least observational studies initially can be initiated rather than interventional studies. So these are the possible things, all these procedures we use, not much Virechanas, very few conditions we use Virechanas. Post-Shodhanas we can use Basti, Nasya, Lepa, Pradeha, Alepas, and Abhyanga, Mrudusvedana, Parisheka, Shirodhara, Shiropichu, Kavala Gandusha, and Chaloka Charna. Based on the condition, we can use different Panchakarmas and the Upakramas. So here we have categorized the 5 strategies. Actually, just I will go with the headings only. Strategy 1 is a chemo prevention, to provide primary prevention to the susceptible population to reduce their chances of developing the disease through both pharmacological and non-pharmacological interventions. This is the one strategy where we can work out. Strategy 2, the number of patients coming in these categories. That is I am telling. So the add-on therapies which will aid to the tumor size reduction and address the side effects associated with the chemotherapy, radiotherapy, and surgery. Second one, So usually we see in the post-surgical cases of glioblastomas where brain tumors are tend to grow within 3 months, 6 months, or within a year. In such conditions, we have seen that by introducing these Nasya, Lashuna Rasayana, Pipali Rasayanas, the tumor size is reducing. We have seen glioblastoma patients and many ependymoma and many other neurofibromas. In such conditions, we see the results. Strategy 3 is a standalone. Few conditions where the patient is not fit for chemo and financially is not fit for that, and either the patient, we are talking about the early detection and all, and in a government setup sometimes it happens that the patient has diagnosed now that the treatment date is given next year. That is also going on. We are detecting early, but we are treating them after 1 year. So such a conditions, the patients are there, that time we can introduce our treatments also. Standalone therapy. Prevention of recurrence is a very nice area where we can work safely at present, because nobody is going to be much, because there is no any drug intervention problems, or there is much intervention is not there. So just prevention, at least 2 years, 3 years continuously we need to follow, because the patients till now, in my experience of 7-8 years, the patients are till 6-7 years they are following some few patients. So that is a follow-up will be very good in such conditions. We need to document those patients. Strategy 5, again, chemoradiation therapy to address the untoward effects of the chemoradiotherapy to prepare the patient in prior, so that the patient can tolerate the effects and expecting minimum untoward effects. This is also very important, because the patient to complete the chemotherapy, that gives a good results and the good survival of a patient. If he is dropped in between any reasons, so then again that compliance will not lead into better results. If you make them to adhere to the chemotherapy and he can best tolerate and he complete the course, that is also very good, and that we are helping for the outcome of the patients in terms of curative management. So few cases, just I will not go in detail. These are the medications used for lentiginous melanoma, one of the rarest conditions of the skin malignancies. So these are the medications used for to treat that patient. So that patient, this is the before and after treatment, the patient's images. So the patient came to us with a discontinued radiotherapy schedules. He has taken few cycles of radiotherapy, and next he stopped the treatment, and for 1 year these lesions were gradually increasing, and he doesn't saw any response, and he left out the treatment. 1 year he was there in home, and later he came to us, and next we have treated him for 2 to 3 months with the internal medications, even grithas and all what I have told, but no response was there, and then we have posted him for Virechana. So once we have given the large amount of ghee, immediately within Snehapan of the 7th day, almost 50% of the lesions, as we see in psoriasis and other conditions, the same thing was observed in this patient. So again, after Virechana, and he has taken voluntarily, he has taken 2 to 3 Virechanas after that by himself, and now till now he in between he comes, everything is okay. He is in surveillance with the allopathic doctors also. As for their schedule, he goes do the checkup and he comes. So this is one of the rarest conditions with a good prognosis. We have treated this case. Another is the squamous cell carcinoma of the left tonsils with a metastasis. So these were the condition before. So just the image, this is the wound which is the metastasis of that, and later with the treatment it was almost healing, and in between the patient has dropped the treatment, but it was almost healing conditions. And thyroid cancer conditions also, we usually use these drugs, Kanchanara, Varunadi, Nityananda and Shugruadi Lepa. Many things are there in that. Again, we use in such conditions Vardhaman Pipali also conditions. So gradual decrease we can see in the ultrasound. We have not gone for this one, CT and other things repeatedly is not possible. Usually advise ultrasound to see the status of the glands. This was considerable reduction was there. CLL, as I was telling about the CLL patient, it was now till now 4.5 years. He's in follow-up with us. So initially he has came with pedal edema, productive cough, irritation in throat, weakness, feverishness, and it was cachexia. Completely he was drained out, like he looks like that at that time. So he was treated with Ayurvedic as well as the Siddha medications. These are the medicines which we used at different times. Guduchi Rasayana and Estimadu Rasayana particularly we have given to that patient, and all other things, routine things are there as per the symptoms and other things we have given. So this patient is still now he is following up with a TLC is raised, but no any allopathic. Starting from initially, he has not taken any allopathic treatment. Till now, his TLC level is little bit more, but physically everything is okay. Is working. His physical condition is very good. No any symptoms. So just he comes for the follow up, and we have kept him on just a maintenance drugs. In between, we give. This is the protocol. This is our limitation. I cannot assure you any curative and other things. Just this is better you go there, do the treatments. Anything is problems, chemotherapy side effects, we will manage, and later we can go for a prevention aspect. Likewise, we explain them, but still the patient insists, we'll take a consent and we'll start the treatment for those patients. So these are the medications which we have given for that patient. Till now that patient is coming. I think it's 5 years. I think 5 years. This patient is in follow-up, and you can see the PET scan in 23. That time only have taken the PET scan. Now recent PET scan is there. It is also normal. I have not updated that. See, this is metabolically active lesion in the upper inner quadrant of the left breast, hyperdense lesion in the left occipital and right parietal region, metastatic. So no other metabolic active. So if you see on the breast lesion, non-hypermetabolic, hypodense tissue density in the upper inner quadrant of the left breast, that lesion is there hypodense, but it is not non-hypermetabolic. And if it is metastatic in the brain, no obvious metabolic active lesion could be noted in the neuroparenchyma. So that is totally disappeared. And the new finding was a teeny nodule which has been seen in the lungs, but they are not in a position to say whether it is active or not. After that, PET scan also have taken. That teeny nodule is still present, and breast same situation is going on. So this is the patient which we got with only standalone therapy. Such cases are also there. Need to check on that. So the overcoming the challenges in case of integrative medicine, trust building, as I have told initially, we need to build the trust because understanding the weakness and the strength of each other, and standardization, that is the develop uniform SOPs for integrative care pathways, and evidence and safety, ensure rigorous scientific validation and avoid unproven or unsafe interventions, and policy support, advocate for inclusion of integrative models in the national cancer care guidelines. And the way forward is establish national level for integrative oncology like CIO, promote Ayush integration in tertiary cancer hospitals, train the next generation of integrative practitioners, build public trust through transparent patient-centered care, and the Center for Excellences need to be more and more developed and strengthened in this direction. Thank you.
Thank you so much, sir, for that insightful and thought-provoking presentation. Now I would like to request Dr. Reshmi ma'am to kindly felicitate Dr. Huddar, sir. Light off. जाओ जाओ. Next in the session, we have Dr. Alex Hankey, sir. We welcome you, sir. Dr. Alex Hankey, sir, Professor Emeritus of Yoga, MIT World Peace University, Department of Biosciences and Technology. With his vast international experience, he beautifully bridges the gap between traditional wisdom and modern science. I would like to invite Dr. Deepu Manohar, sir, to kindly come forward and give a Brief introduction of our next esteemed resource person, Dr. Alex Hankey, sir.
Good afternoon, everyone. Sorry, good morning, everyone, again. It's my honor to invite Professor Alex Hankey, an eminent theoretical physicist and distinguished scholar who bridges the gap between the modern and the ancient wisdom. So Professor Hankey did his BA from Cambridge University and his PhD from Manchester's Institute of Technology in Theoretical Physics. It is followed by the prestigious Linman Postdoctoral Fellowship in the year 1972 to 1973 held in Stanford Linear Accelerator Center. He served as a founding faculty member in Maharishi International University and has for decades in the advancement of consciousness studies, integrative medicine, and scientific understanding of yoga and Ayurveda. He has authored over 130 peer-reviewed journals and is in the editorial board of 6 scientific journals. His recent book, The Science of Medical Astrology, a scientific proof for Jyotisha, further exemplifies his interdisciplinary brilliance. So his present work include translation of the work Maharshi Patanjali Yoga Sutra. And with great respect, I request everyone to join me in welcoming Professor Alex Hankey. Welcome, Mr.
Jai Gurudev. I would like to thank the organizers of this wonderful conference, Arogya Sangam, and particularly the organizing committee and the officials and the dignitaries on the dais for giving me this opportunity to present my ideas about biology. Could you put the first slide on? Oh, I have something here. As you all know, there is a huge disparity between modern biology and what we learn about life from the Ayush systems of medicine, particularly Ayurveda and yoga. I'm giving you, therefore, a new model of biology that I have developed over the past 5 to 7 years with my colleague Anup Kale, particularly at the MIT World Peace University. This biology agrees with the Ayush systems of medicine. It gives us a holistic picture of biology, and it should be used as a foundation for teaching integrative medicine throughout India initially and hopefully throughout the world. So there is, in 5 parts, I'm presenting this paper, this presentation, together with preliminary ideas. There is a necessity for adaptability. It's not given in Western biology. Without it, no organism can survive. And I want you to listen very carefully to this statement. In the current model of biology, the molecular biology model of biology, due to J.D. Watson, every organism in the wild would, well, metaphorically, drop dead. It would die because it could not adapt to changes in the surroundings. We know that modern human life has changed the surroundings to an extent which has put millions of organisms in peril, and there is a terrible extinction going on, an anthropomorphic extinction. Now, the new model of biology we've developed contains a new biology of adaptation due to the epigenetics of cell function and the biochemical pathways which were just originally supported by molecular biology, are now sandwiched between epigenetics and the genetic basis of creating enzymes. So we have what we call a sandwich model of biology, and the genetics are in Watson's molecular biology of the gene, but the epigenetics are governed by two very, very well-published principles which are not taught at all in biology, because the authors of such texts as Campbell Biology do not keep up with new research properly, and they do not understand what new research should be considered fundamental. And I want you all to understand that the biology texts that you use to study biology are 50 years out of date. They are really appalling and a disgrace to the scientific community, the biological community. So what happens is that there is an area of physics which is taught in high schools but little known. It's called the study of critical instabilities. It originated with the famous scientist Johannes van der Waals, and these instabilities are absolutely essential in all life. They are known to be present in all life because of fractal physiology. So let me proceed to tell you a little more of the background. Ayush systems present a holistic systems understanding of life as presented in my many or several papers on Ayurveda dating from 2001. Ayush Tridosha correspond to basic systems functions: input, output, vata, turnover or processing, metabolism, pitta, and storage, kapha. You need these systems functions in order for any open system to progress and to reproduce. Understanding Ayush will result in advances in biology. This was a fundamental concept that I published in a paper in Evidence-Based Complementary and Alternative Medicine, ECAM, in 2005. And over the last 20 years, I have been pursuing those ideas, and they've proved extraordinarily fruitful. Understanding Ayush systems of medicine can be used to make fundamental advances in biology. So the concept of Ayus, the life force in Ayurveda, corresponding to the life breath prana in yoga, is they're both holistic properties of the organism. And this is impossible to understand from the present understanding of biology, Watson's molecular biology of the gene. So the question is, how do we transform biology so that it does not conflict with the knowledge of life from Ayush? And once you have that, clearly you have an understanding of biology that can be used as a genuine basis for understanding integrative medicine. That is the object of this presentation. So, all organisms need adaptability. Without adaptability, they cannot survive. Adaptability of this nature is not included in molecular biology. So, as I said at the outset, current biology presents a picture of life which is absolutely nonsense when you look at the need to adapt. All organisms possess the ability to adapt. They adapt to changes in the environment, pH, red temperature, redox potential. The archaea, the earliest organisms, adapted to extreme environments very quickly. They're called extremophiles. And if you go to the bottom of the ocean and you look in deep sea volcanoes where ocean spreading, the spreading of the ocean floor is taking place, you find extremophiles, and they can survive to quite extraordinary high temperatures, like 120 degrees. And they have been doing that for over 3 billion years. But that is not included in modern biology. Ridiculous. They adapted to the most extreme environments, and this domain of life, the archaea, contains the most extremophiles. So the sandwich model of biology is conceptually new picture of biology, which I published together with my Associate Dean, Anup Kale, in the Journal of Ayurveda and Integrative Medicine in 2023, and I would suggest that everyone really interested in this presentation read that paper. It's not an easy paper to read. The new model sandwiches the biochemical pathways supported by the genetics between the genetics and the epigenetics. So we call it a sandwich model of biology. And in India, I like to call it the Vada-Pao model of biology, because a Vada-Pao is an absolutely paradigm of a sandwich in India. The genetics generate the enzymes, and the epigenetics bring adaptability to the system. The third point, that it's the genetics are just as what we know from the molecular biology of the gene. The DNA at the bottom of the picture stores the information, which is transcribed to RNA, translated to polypeptides, which are combined into enzymes, which support the biochemical pathways. The epigenetics is much, much richer than anyone has previously really understood. It's the epigenetics which actually creates a wonderful, it's called complexity, and it is the origin of complexity in biology, which is rich enough to produce understanding of the life force. It's called the life force in naturopathy and in homeopathy. In Ayurveda, we call it Ayus, and in yoga medicine, it corresponds to prana, the life breath. The epigenetics incorporates two fundamental principles. One is called hormesis, and there have been about 2,500 papers written about hormesis and its applications, but none of them have got down to the fundamentals of why hormesis has to exist. They talk about its use in adaptation to this and that, but not as a fundamental principle in biology. It activates resistance to toxins. And what happens is that there is a feedback loop. And if a toxin poisons a gene, an enzyme, then the products of that enzyme are reduced. So there is a feedback loop which actually causes more production of that enzyme. And then the biochemical pathways are maintained in balance. Otherwise, they would be driven out of balance by changes in temperature or pH, and the organism would not survive. So you get a basic adaptability produced by hormesis. But then you have this property of fractal physiology, and the fractal physiology is created by optimizing the response. Clearly, if you have two organisms, one of which is not optimized and the other is optimized, then the one which is optimized will become more prevalent. It will outcompete the other organism. So over 3 billion years ago, the organisms which optimize their response to changes in the environment became the dominant organism. And by this means, fractal physiology, which expresses, for technical reasons, the optimization of your response to changes in the environment, became the dominant property of all organisms, even the archaea. So archaea, protista, all the blue-green algae, and so on, and the three kingdoms of life, the fungi, the plants, and the animals, fungi including Saccharomyces and things like that, simple cells, they all adopted this pattern of optimization of response. The optimization involves an area of physics that I wrote my PhD on, and you get these really fascinating properties of organisms resulting. So I've covered this. Hormesis increases an increase in a biochemical causes a decrease in enzyme level. A decrease in a biochemical on a biochemical pathway causes an increase in the enzyme level by feedback loops. And as the biochemical levels change due to changes in the environment, so does the enzyme production. Absolutely fantastic degree of sophistication, which has not been previously suspected in life. Now, the next thing is, there is a thing that I've called and named a response curve. It describes details of epigenetic response. And it's not simply switching an enzyme from being off to being on. That is like, it's a discontinuous change, and it's like a phase transition, and it has very many disadvantages. You get metastable states occurring where the phase transition has not taken place. So what you do is you create a continuous curve of change where there is a change in the curvature called the point of inflection, and that change in curvature is the place where you get a critical instability, and that is the place where organisms center their regulatory control. So you get a vertical point of inflection on the response curve, that's 2 lines up, and it produces a critical instability known to characterize fractal physiology. So the significance of the critical instabilities is this. This is the last main slide. Hormesis couples them into what we call higher order critical points, a concept that I developed in my PhD thesis. Fractal physiology creates optimized regulation. Biology, because the higher order critical points couple together and they form a completely holistic internal control system for living cells. The critical instabilities controlling adjacent biochemical reactions are coupled together through what are called critical fluctuations, and biology thus becomes holistic, and a model of the life force, ayus or prana, is defined. So they become higher order critical points, and a critical point of ultra high order with many hundred participating critical points results, and this has all the properties. It's extraordinarily complex theoretical understanding. It's completely revolutionary. It has all the properties of the life force or prana. So here's the summary. A new biology of adaptation incorporates hormesis and fractal physiology. the analysis of the response curve shows that you get a critical point, a vertical point of inflection, of critical instability, and this is the reason for the critical instabilities that give rise to fractal physiology. They maximize organism prevalence, they cause fractal physiology to emerge, and hormesis acting on different enzymes causes various critical instabilities to couple into critical instabilities of higher order. And when this happens, this has two effects. They make the organism functioning holistic, as Irish systems of medicine have always maintained. Life is a holistic structure. Science banished the life force in the 1930s, but this restores it. So we have a new model of life and the life force, which possesses all the properties attributed to it by Irish systems of medicine. And this is the reason why ancient wisdom was right all along. So I say thank you to my Guru, His Holiness Maharishi Mahesh Yogi, and I say thank you to the conference for giving me this opportunity to present. And I'm sure I've gone over my half hour. How am I doing? Namaskar.
Thank you so much, sir. I would request Dr. Reshmi Pushpa ma'am to kindly felicitate Dr. Alex Hankey, sir.
One final offer. If you want to know more about what I said, please come and talk to me after.
Now I would like to invite our chairperson, Dr. Reshmi ma'am, to kindly come forward and share her valuable remarks on the presentation.
Good morning, all. I thank the organizers for giving me this opportunity to chair the session by two eminent scholars in the field of medicine. Dr. Vittal Huddar, sir, had already attended our last conference last year. He was online the last year, and we got an opportunity this time to have you with us physically. So last year he had spoken on 10 to 15 case studies on cancer, which was very helpful for Ayurvedic scholars. And this year his material or his presentation was so comprehensive that it addressed all the aspects of integrating oncology. So for students who are the major participants for the seminar, I would request you all to also go through sir's paper, which is there in our compendium, which also reflects all the topics that he taught or spoke today. And he has also, put in 5 case studies that he has presented here. So you can again go through those materials. And what I would like to once more reiterate is that the area of oncology is one that each one of us should look into because of the non-communicable diseases surge that is happening. So that is a key area that we should concentrate. And we have All India Institute of Ayurveda, which is pioneering in developing protocols, research methodologies, training or capacity building for practitioners, students. It is also looking into the academic frameworks. We have also understood that a lot of protocol building is happening. So there's a lot of things sir has actually enlightened us through his talk. And if we carry forward or when we have any difficulties or we personally want to learn anything, that's a great opportunity that we have such centers which we can also approach to learn. So as students, we should try to learn about it. Then coming to Alex Hankey sir's paper or presentation, I would say I'm awed. I have no words to speak. Whenever as a scholar or student, always I have put aside Alex Hankey sir's paper because it was so difficult to read for me. So this is the first time I would say that I have actually concentrated and heard him. Because James Publications sir has always been in the editorial board and he's always been writing for JAIM. And to tell frankly, I have never read even one of his papers because I could never read it. So, but when I heard him today, the concept that he shared of epigenetics and genetics, how Ayurveda or Ayush systems or all the traditional systems, how they can actually bring in that adaptability or change. Like it was actually kind of sandwiching also Huddar sir's presentation to the fundamental concepts of Ayurveda, dosham, doshyam, balam, kalam, analam, vaya, all those 10 factors that we should constantly monitor to bring about the preventive oncology aspects. So I felt that way, these two talks or presentation was in sync to each other because Sir was talking about preventive oncology and he was highlighting the importance of Rasayana, where Sir also told there are so many models in our country that we should look at geographical things that we can do as a preventive model. I would also like to share one example where in Kerala we have this practice of Kayachikitsa, which is called as the rejuvenation therapy done in the month of the rainy season. So this is like even if we there is no history of cancer and we want to like integrate a model into practice, every region can take up some season of theirs where they can do a shodhan, which is like Swastha Shodhana. So that was a very good concept Sir put forward. So there were so many things in the presentation which are like that. I think we should again go through those materials. Then only we will be able to adopt some of those principles into our practice and enable us to become good practitioners. Thank you so much, Sir Huddar sir and Alex Hankey sir, for gracing us, giving an opportunity, being with us. Thank you very much.
Thank you so much, ma'am. Moving ahead, I would request Dr. Dhanya V. Nair, ma'am, to kindly felicitate our chair and co-chairperson. I would now request Dr. Deepu Manohar sir to kindly felicitate Dr. Dhanya V. Nair, ma'am.
Professor